Unit 4, Assessment of Psychopathology. 4.2 Clinical Assessment, Definition and Elements. You already know that a standardized procedure is followed to define and diagnose a mental condition as a psychological disorder. This implies that assessment of psychological disorder also requires formal instruments and techniques. BAPCH, 1997, has defined clinical assessment as the collection, organization, and interpretation of information about a person and his or her situation. The question arises, is any kind of information from any source useful for making a clinical assessment, or should it be specific information from reliable sources? The answer lies in the requirements of assessment. Clinical assessment has the following elements for which information must be collected. Rosenberg and Koslin, 2011. Diagnosis. Information is obtained to make a diagnosis of a possible psychological disorder / problem. Course. Information that helps to monitor the course of the psychological disorder, i.e., whether the symptoms will worsen or improve over a given time. Treatment. To determine the type of treatment that will be beneficial and the progress of the treatment. Clinician's perspective. The theoretical perspective in which a clinician has been trained will influence the required type of information. For example, a clinician trained in the behaviorist's tradition will be interested in the role of family environment and learning in causing a disorder. Setting. The extensiveness and comprehensiveness of information is dependent on the setting of assessment. The information collected for a research project will be more extensive and comprehensive. Finance. Collection of information depends on the payment, that is, focus will be more on obtaining the information that is paid for. Reliability, validity, and cultural bias of assessment tools. Assessment tools must be reliable, valid, and culturally fair. Reliability means consistency of measurement, that is, same scores should be obtained for a person when assessed by different clinicians using the same method. For example, if a person scores high on a test of trait anxiety when assessed by one clinician, he should get the similar score when assessed on the same test by another clinician. Secondly, the assessment tools must be valid, that is, they should measure what they intend to measure. If a test intends to measure trait anxiety, then it should have items that measure the anxiety as a trait, a stable personality characteristic, rather than items that measure anxiety temporarily caused by a situation like an exam or an interview. An assessment tool may be reliable but not valid. Thus, a measure of trait anxiety may show consistent scores for a person assessed by different clinicians, but its items may not be appropriate to measure trait anxiety. Cultural bias is another important aspect that may affect the validity of the assessment tools. Many assessment tools are culturally contextual, i.e., constructed by the clinicians and / or researchers belonging to a specific culture and for the individuals who also belong to that same culture. Hence, culture bias may affect the construction as well as scoring of assessment tools. If a culturally biased test is used for assessment of individuals belonging to a different culture, or if scores obtained for people of different cultures are compared with each other, it may not provide the valid information. Poitinger, 1995. 4.3 Types of clinical assessment. Clinical assessment includes information about the biological, psychological, and socio-cultural factors that may underlie the psychological disorders. Let us study the details of each type of assessment in the following sections. Rosenberg and Koslin, 2011. 1. Biological assessment. A. Neuroimaging techniques. One of the underlying causes of some psychological disorders may be structural and functional abnormalities of brain, such as schizophrenia. Neuroimaging techniques are used to measure such abnormalities by providing brain scans, through X-rays, CT scan, MRI, fMRI, and PET. Assessment of the brain structure through X-rays and computerized axial tomography, CT/CAT scan, and magnetic resonance imaging, MRI. X-rays is the oldest neuroimaging technique, which is used to take pictures of the patient's brain. It is now used in an advanced technique, called computerized axial tomography, CT/CAT. Tomography is a Greek word, which means section. In CT scan, a moving beam of X-rays penetrates a horizontal cross-section of the brain and scan it at 360 degrees. An X-rays detector detects the X-rays as it passes through the cross-section, and an image is formed which shows any anomaly in the brain structure, such as increased or decreased tissue density, lesions, and tumors. This procedure is repeated with the different horizontal cross-sections of the brain. The multiple X-rays images obtained are fed into a computer, which integrates the information and produces two-dimensional image of the brain. It is an invasive procedure as X-rays pass through the brain. Overexposure to X-rays can be hazardous as it may cause mutations and cancer. Magnetic resonance imaging, MRI, is a more precise diagnostic technique as it measures and provides sharper images of the more subtle abnormalities of the brain which may go undetected by CT scan. The person is put into a cylindrical hollow with strong magnetic fields at different angles. When the first magnetic field is switched on, it causes the atoms of the body to align with it. Then second magnetic field at a different angle is switched on, which causes some of the atoms aligned with the first magnetic field to move away from it and align with the second magnetic field. When the second magnetic field is switched off, the atoms aligned with it try reorienting to the first field. The reorientation causes the atoms to emit a signal. These signals are recorded by a computer, which forms the image from these signals. These images help to detect the location of the atoms in the brain. Any changes in the location and density of the atoms in the patient's brain in comparison to the images of the normal brain indicates a structural abnormality. MRI helps in the detection of excessive growth or shrinkage in the brain structures. For example, enlarged ventricles and shrinkage of the gray matter can be seen in some patients with schizophrenia. Schneider-Axman et al., 2006. It is a non-invasive and a safe procedure as no harmful rays or chemicals enter the body. Assessment of the brain function with PET scans and fMRI. Sometimes abnormal brain functioning rather than the abnormal brain structure may lead to psychological disorders. Different areas of the brain are responsible for different functions, such as talking, reading, holding, judging, etc. When a specific area of the brain is involved in a function, the blood flow to that area increases. Examining the difference in the blood flow in different brain areas can tell us the involvement of that area in a given function. For example, there is an increased blood flow to the limbic system, especially amygdala, when strong emotion like fear is experienced. Pishatar et al., 2003. Positron emission tomography, PET, is the functional neuroimaging technique used for measuring blood flow in the brain. A very small amount of a radioactive substance is introduced into the bloodstream. When a person performs a specific task, the blood flow increases to the brain area activated for carrying out that task. As the blood flow increases, the radioactive substance also increases in the active area of the brain. The measure of radiations in the different, more active and less active, areas of the brain are fed into the computer, which integrates the information and produces a three-dimensional colored image of the brain with different levels of activity in different areas. Brighter colors typically indicate greater level of activity. Though PET is high in precision, but it is not used frequently because of two reasons. First, It is a highly invasive procedure where radioactive substance is introduced into the bloodstream, and second, it is a very expensive and time-consuming procedure. Functional magnetic resonance imaging, fMRI, is the most widely used method for measuring human brain function for research purposes. The activated brain areas draw blood more quickly than the oxygen carried by the hemoglobin in the blood can be used. Hence, the activated areas of the brain have more oxygenated blood than the less or not activated areas of the brain. This difference in the oxygen level of blood in differently activated brain areas is translated into fMRI images. It is a non-invasive procedure as it requires neither radiation nor any chemical for measuring the brain function. It must be noted that PET or fMRI cannot precisely detect which parts of the brain are on or off while performing a task. Brain is never switched off, not even during sleep. These assessment techniques can only measure a relative activation of the specific part of the brain while performing a task. B. Biochemical assessment. Level of neurotransmitters and hormones. Biochemical imbalances may lead to psychological disorders. For example, low level of a neurotransmitter, GABA, gamma-aminobutyric acid, is implicated in generalized anxiety disorder, GAD. Low level of a hormone, thioxin, is involved in depression. There are several ways in which levels of neurotransmitters and hormones in the body can be studied as described below. Magnetic resonance spectroscopy, MRI. It is a non-invasive procedure to measure the changes in the neurotransmitter levels in the brain. It compares the chemical composition of normal brain tissue with the patient's brain tissue. The machine for MRI is used to perform magnetic resonance spectroscopy. Hydrogen ions or protons of metabolites. Metabolites are the product of metabolism, are analyzed. For example, homovanillic acid is the metabolite of the neurotransmitter, dopamine. Some other metabolites of various neurotransmitters are amino acids, choline, creatine, etc. MRI measures the frequency of these metabolites, which are then plotted on a graph. By comparing the frequency of a metabolite in a patient with a normative group, abnormally low or high tissue growth in the specific brain area can be detected. Blood, urine, and cerebrospinal fluid samples. The level of a neurotransmitter in the body can be inferred through the level of its metabolite in blood, urine, or cerebrospinal fluid. For example, to test the dopamine hypothesis, increased level of dopamine leads to schizophrenia. The level of its metabolite, homovanillic acid, was tested in the cerebrospinal fluid of the patients with schizophrenia. Certain hormones have also been found to be involved in psychological disorders. For example, cortisol, a stress hormone, has been reported to be at an elevated level in the patients with depression. Further, low levels of thioxin, a hormone secreted by thyroid gland, has been implicated in depression. The level of thioxin can be measured through a blood test, Fenigit al. 2004. PET techniques. The key aspect is that there are specific receptors in the brain for each neurotransmitter. For example, dopamine has 5 receptors, form D1 to D5, out of which D2 has the maximum affinity for dopamine. Some psychological disorders may involve either abnormally low/high number of receptors or hypo/hypersensitive receptors for a specific neurotransmitter. The proliferation or sensitivity of the receptors can be found through PET technique, which uses ligands, radioactive molecules mimicking neurotransmitters. Let us say, a researcher wants to study the receptor system, X, for a neurotransmitter X. To study it, a ligand that mimics neurotransmitter X is injected into the bloodstream of a patient. It travels with the bloodstream and binds itself to the receptors X. The radioactive substance in the receptor system X emits signals which are detected by the computerized system and translated into images. This technique helps the researcher to examine the location as well as the functioning of the receptor system. C. Neuropsychological assessment. With the help of neuropsychological testing, brain functioning is inferred through measurement of behavioral responses. Neuropsychological assessment helps to make a distinction between the neurological and psychological causes of a dysfunction. For example, memory problems may be due to neurological damage as well as due to a psychological disorder, such as depression. Further, it also helps in the detection of brain damage which may be the underlying cause for a psychological problem. For example, damaged prefrontal cortex may lead to drastic personality changes. Neuropsychological assessment includes tests that measure simple, matching the verbally presented name of an animal to its picture, to complex abilities, problem-solving tasks. Examples of neuropsychological tests are Bender Visual Motor Gestalt Test 2, 2nd edition, Bender, 1963, Brannigan and Decker, 2003, Facial Recognition Test, Bentonit al., 1983. In the Bender Visual Motor Gestalt Test 2, there is a series of patterns ranging from simple to complex and the patient is asked to reproduce those patterns. This test measures the visual motor coordination and helps to detect memory problems and learning disorders. Brannigan and Decker, 2006. The facial recognition test has several variations. In one such variation, the patient is shown a picture of the target face and then shown 6 pictures out of which he/she must recognize the target face. Along with individual neuropsychological tests, there are neuropsychological batteries also which consist of a group of tests, each measuring a specific ability. For example, Illyria Nebraska Neuropsychological Battery, Golden, Hamk, and Purisch, 1980, has 14 tests which measure different abilities. The Halstead-Riordan Neuropsychological Battery, which was developed by Halstead and modified by Riordan and Davison, 1974, consists of 10 tests measuring different abilities. The neuropsychological batteries can be administered as a whole or in parts, i.e., the neuropsychologist may administer only some of the specific tests from the battery according to the requirement based on the patient's report. While the functional neuroimaging detects the activation of a specific area of brain during performance of the given task, the neuropsychological testing gives a general idea of brain functioning, i.e., efficient task performance, effortful task performance, failed task performance. Based on the localization theory, brain's 4 lobes are specialized in performing specific tasks. For example, frontal lobe is responsible for problem solving, decision making, error detection, etc. Neuropsychological tests can suggest the damaged brain area /S. The neuropsychological assessment is less precise in comparison to the advanced scanning techniques, such as CT scan, MI, fMRI, PET, but it is useful as it is non-invasive, far less expensive and does not require machinery and tools. Nevertheless, the results of neuropsychological assessment must be corroborated with the neuroimaging techniques before planning the treatment and rehabilitation of the patient. D. Psychophysiological assessment. According to Grings and Dawson, 1978, psychophysiology is a field of study that examines the relationship between the psychological events and the accompanying bodily changes. For example, anxiety may lead to excessive sweating, breathlessness, palpitations. Some of the psychophysiological measures are electrocardiogram, ECG to measure the heart rate, electroencephalogram, EEG, to measure brain activity which may help in detection of epilepsy, brain lesions, portable BP machine to measure blood pressure, electromyogram, EMG, to measure muscle tension, and galvanic skin conduction response, GSR, to measure skin conductance or electrodermal response. Strong emotions, like fear, activates the sympathetic nervous system, which in turn activates the sweat glands that produce excessive sweat, which increases the electrical conductance of skin. However, a drawback is that sympathetic nervous system is activated in other emotions also, such as excitement or joy, which may also lead to excessive sweating, thereby increasing the skin conductance. 2. Psychological assessment. Psychological functioning includes cognitive, emotional, and behavioral content and processes, all or some of which may be disrupted in a psychological disorder. Further, these processes determine an individual's ability to perform daily life activities at present and in future also. That is, the greater the disruption in cognitive, emotional, and behavioral content and processes, the more severe the disorder will be and poorer will be the prognosis. Hence, it is important for the clinicians and researchers to assess an individual on these aspects through various psychological techniques, such as clinical interview, psychological testing, and behavioral assessment. A. Clinical interview. A clinical interview is a question-answer session where the clinician asks the questions to patients about their symptoms, relevant history, medical, educational, legal, personal, social, and occupational functioning. 3 types of information can be obtained from the clinical interview: content of the patient's answers, the way the questions are answered, Weston and Weinberger, 2004, and the questions which are avoided or not answered. Clinical interviews can be structured, semi-structured, and unstructured. A structured interview consists of a fixed number of questions that are asked in a predetermined order. An example of a structured interview is the structured clinical interview for DSM-4, Axis-I and II, SID-I and SID-IE, First it al. 2002. It is usually used for research purposes. It consists of different modules based on different diagnostic categories given in SMIV-TR. In each module, first question is to find the presence or absence of symptoms of the specific diagnostic category. If the patient's answer to the first question is in negative, then the rest of the questions of that module are skipped and the clinician moves to the next module. The SID gives a quick information about the presence or absence of a disorder, however, it does not provide the opportunity to interpret the patient's answers and to probe further for relevant information. For this purpose, many clinicians use a semi-structured interview as they want to ask some specific questions regarding the patient's presenting complaint. A semi-structured interview consists of a list of standard questions to which the clinician adds own questions. These follow-up questions help the clinician to get additional information or to corroborate and verify the information obtained through standard questions. During the semi-structured interview, the clinician may examine the mental status of the patient to assess his/her psychological functioning. The mental status examination includes questions about the patient's personal information, presenting complaint, history of the presenting complaint, daily life functioning, reasoning ability such as simple arithmetic reasoning, memory and judgment, orientation in time and space. For example, the clinician may ask the patient's name and other personal details, like date of birth, address, to check orientation to time and space. The question pertains to the time of the day and present location of the patient. To check working memory, a digit span test can be used. The patient's responses to the standard questions of mental status examination helps the clinician to develop hypotheses about the diagnosis, dysfunction/S, course, and prognosis of the disorder. It gives an overall assessment of psychological functioning of the patient, Rosenberg and Koslin, 2011. An unstructured clinical interview does not have fixed questions. the clinician asks questions according to his/her understanding of the client's problems. The clinician is free to ask questions which are specific to the problems and issues of the patient. Mostly, patient's response to a previous question serves as a cue for the clinician's next question and so on. A major disadvantage of the unstructured interview is low reliability. Since different clinicians may ask different questions as per their understanding of the patient's situation, so they might obtain different sets of information, thereby making different diagnoses for the same patient. On the other hand, the structured interview is reliable. However, it may not be valid as it may ask questions that are not relevant to the patient's problems. Mayer, 2002. A semi-structured interview combines the qualities of both structured and unstructured interviews, which ensures greater reliability and validity. Additionally, irrespective of the type of the interview used, the clinicians make use of patient's self-report and their own observations of the patient during the interview sessions. Patient's self-report. Since all the symptoms are not directly observable, such as worry, fears, hallucinations, etc., so clinicians depend on the patient's self-report to develop a hypothesis about the patient's problems. The clinician must know about the patient's history, such as developmental, educational, family, social, occupational history, to understand the presence of psychosocial stresses that may play a causal role in the patient's current problems and disorder. The information about psychosocial stresses provides the clinician a perspective or a framework to diagnose the current disorder as adaptive or a maladaptive response to those stresses. Kirk and C. 2004. Though self-report is an important source of information, however, it may have problems regarding authenticity, as it may get affected by malingering, factitious disorder, and biases. Malingering means the patients may give an exaggerated account of their symptoms for a personal gain, such as monetary benefit or escaping from an undesirable situation, like arrest. Factitious disorder is pretending of having symptoms or even induce symptoms to take the role of a sick person for getting attention from significant others or clinicians. Any obvious cause, such as personal gains, for example, money or escape, is not present. Biases may also creep in self-reports intentionally or unintentionally. For example, since the reporting of history is retrospective, so the patient depends on memory, which at times may fail, causing the patient to fill the gaps through confabulations. Emotions may also lead to bias, leading the patient to maximize the negative or disturbing events and minimizing the positive events. Sometimes, patients want to portray themselves in a certain manner, which also cause a reporting bias. Mayer, 2002. In some cases, due to psychological dysfunctions, such as disorientation to time and space or delusions, the patient may confuse reality with imaginary events, which may lead to inaccurate self-report. Yet another source of bias in self-reporting is embellishments, i.e., to look good in front of others. The patients may report an exaggerated account of their achievements. Due to the possibility of inaccurate self-reports, the clinician must also make thorough observations of the patient, so that in case of incongruence between self-report and observations, they could cross-check with other sources, like caregivers, family members, colleagues, medical and / prison records. Rosenberg and Koslin, 2011. Observations. Observations about the client are an important source of information about the client's problems, issues, dysfunctions, and functional status. The clinician can make observations about the patient's appearance, emotions, behavior, speech, movement, and mental processes. For example, is the appearance of the patient clean? Is he / she appropriately dressed according to the occasion as well as weather? Does the patient express distress / aggression? Are there signs of abnormal behavior, such as inappropriate body language? These observations sometimes provide more valuable information about the patient than the patient's self-report of his/her problems. Thus, a clinical interview is a rich source of information about the patient's psychological functioning and psychosocial stresses. However, its reliability and validity are lower than another assessment technique, the psychological testing, which is widely utilized by the clinicians. B. Behavioral and Cognitive Assessment, Kringit al. 2012. Cognitive behavioral perspective-oriented clinicians assess 4 sets of variables, Salk, Camphor and Phillips, 1970, S equals stimuli, the environmental situations that precede the problem. The clinician may try to identify the stresses that tend to elicit a given maladaptive behavior. O equals organismic, referring to both physiological and psychological factors assumed to be operating under the skin. Perhaps, the client's fatigue is caused in part by excessive use of alcohol or by a cognitive tendency toward self-deprecation manifested in such statements, "I never do anything right, so what is the point trying?" R equals overt responses. Clinicians determine what behavior is problematic, as well as the behavior's frequency, intensity, and form. For example, a client might say that he/she is not assertive. Does the person mean that he/she is not assertive in all situations and with everybody, or it's specific to situations and people? C equals consequent variables, events that appear to be reinforcing or punishing the behavior in question. For example, when the client does not show assertiveness, it pays by maintaining the status quo, thereby keeping the person from being assertive. A behaviorally oriented clinician attempts to specify Salk factors for a particular client. Skinnerian clinicians underemphasize the O variables and focus more on S, R, and C. Cognitively oriented behavior therapists pay less attention to C variables because cognitive behavior paradigm does not emphasize reinforcement. The information about Salk is gathered by several methods such as direct observation of behavior in real life as well as in contrived settings, interviews, and self-report measures. Belak and Hassan, 1998. C. Psychological tests. Psychological tests are the standardized measures of psychological functions, cognitions, emotions, and behavior. Some tests may measure the general areas of functioning, such as intelligence, personality, while others may measure a specific area of functioning, for example, verbal intelligence, neuroticism, extraversion, etc. Let us see some of the tests in detail. Rosenberg and Koslin, 2011. Cognitive assessment. Intelligence tests are one of the tools to assess cognitive functioning. 2 widely used intelligence tests are the Wechsler Adult Intelligence Scale, 4th edition, WAIS 4, revised in 2008, and the Wechsler Intelligence Scale for Children, 4th edition, WISC 4, revised in 2003. An intelligence quotient, IQ, is obtained from these tests. The different ranges of the IQ scores corresponds to the different levels of the intellectual ability. For example, an IQ range of 85 to 115 corresponds to normal intelligence. An IQ between 70 and 85 implies borderline intelligence, whereas an IQ score of 70 and below indicates intellectual disability. Along with the IQ scores, these tests also give scores on 4 abilities, namely, verbal comprehension, perceptual reasoning, working memory, and processing speed. Further, the WAIS 4 and WISC 4 have age and gender norms, which enables the clinician or researcher to compare the individual's scores on various subtests as well as overall IQ with the group of individuals of same age and gender. With the help of these tests, the clinician can assess the various cognitive abilities of the person. Currently, effect of cultural factors on the test scores have been taken into account, hence the cultural factors have been minimized in most of the intelligence tests. Poetinger, 1995. Furthermore, norms of specific ethnic groups have also been provided to avoid cultural biases. Personality assessment. Different aspects of personality can be assessed through various personality tests and inventories. Personality inventory. An inventory is a questionnaire with items pertaining to many different problems and aspects of personality. Inventories usually contain test questions that are sorted into different scales, with each scale assessing a different facet of personality. Rosenberg and Koslin, 2011. With the help of an inventory, a clinician can diagnose and predict the problems and disorders currently present or likely to occur in a person. Minnesota Multiphasic Personality Inventory, 2nd edition, MMPI-2, Butcher and Rouse, 1996, is one of the most famous and used inventory across the world. It was developed in 1930s to identify mental disorders in patients. In 1989 it was revised, and its items were updated to include racial and ethnic aspects. It is a very lengthy inventory with 567 items which measures a person's cognitive, emotional, and behavioral content and processes and takes about 60 to 90 minutes to be completed. Its shorter version has 370 items. It is available in multiple languages as a paper-pencil test, as audio recording and as a computerized version also. The MMPI-2 has two scales, validity and clinical scales. The validity scales assess the validity of the person's responses, i.e., it checks for malingering, factitious disorder, and embellishments in the person's self-report. Clinical scales measure the symptoms of different mental disorders and problems, for example, schizophrenia, hypochondriasis, depression scales. However, these are indicators for various disorders and do not diagnose these disorders, as the MMPI-2 was not designed to diagnose the various disorders enlisted in DSM-40R. So instead of giving a specific diagnosis, it gives a profile of the person with symptoms of various disorders as indicated by his/her scores on various clinical scales. Projective tests. Clinicians use projective tests to assess those aspects of personality which are not amenable to direct questions of an inventory. Projective tests can be semi-structured and unstructured depending on the type of stimuli used. A semi-structured projective test has less ambiguous stimuli, like in Rotter's incomplete sentence blank. Sentence stems are given which must be completed by an individual, for example, my father, or it may have pictures like in Rosenzweig picture frustration study. In this test, caricatures are given depicting different situations with dialogue along with a blank figure and a blank dialogue box. The respondent is required to imagine him/herself in the place of that blank figure and must respond to the given dialogue in that situation. An unstructured projective test, on the other hand, consists of completely ambiguous items such as ink blots or stick figures, or must draw some figures such as a human figure, house, tree, etc. and tell/write a story about those pictures. A very famous unstructured projective technique is Rorschach ink blot test, developed by Hermann Rorschach, 1884 to 1922. It is based on the premise that the patient imposes a structure to the ink blot which can be used to infer the patient's unconscious conflicts, motives, and desires. The subjective interpretation of the patient's responses by clinicians makes it less reliable and less valid. Anastasia, 1988. These issues were addressed by John Exner, 1974, who developed a reliable scoring system for the Rorschach test. Sultanate al. 2006. Although it assesses psychosis in patients, however, It is not an effective tool for assessment of psychological disorders. Wood, Lilienfeld, et al., 2001. Thematic Apperception Test, TAT, is also a projective technique developed by Christiana Morgan and Henry Murray in 1935. It consists of cards with black and white drawings of situations mostly with people and aims to infer about individuals' motivations, thoughts, and emotions without directly asking them. The test involves asking a person to make a story about the situation in a card. It is presumed that the story constructed by the person reflects his/her unconscious motivations, beliefs, desires, fears, etc. Murray, 1943. The clinician may interpret the responses on their own or they can use the scoring system. Very few clinicians use the scoring system. Pinkerman, Haynes, and Kaiser, 1993. Like other projective techniques, TAT has limitations also in relation to reliability and validity. It is not possible for the clinician to distinguish between what the individuals are thinking, feeling and how they want to think and feel. Lilienfeld, Wood, and Garb, 2000. This makes the test questionable as without directly asking the individuals about their motivations and desires, valid information will not be obtained, or the interpretation of the test responses will not be corroborated. Despite several shortcomings, the psychological testing is a widely used measure of psychological functioning of an individual in a comprehensive, standardized manner. 3. Socio-cultural assessment. You can recall from the definition and criteria of the psychological disorder discussed in Unit 1 that social and cultural contexts are important criteria for understanding a psychological disorder. According to Rosenberg and Koslin, 2011, symptoms cannot be understood in isolation and should be studied in the context in which these arise. Therefore, social factors form an important aspect of clinical assessment, such as family environment, role of community, cultural group of the patient as well as the clinician. All these factors may influence the assessment as well as treatment of the patient. For example, is it the family or the community that takes the decision for the assessment and treatment? In some traditional societies, women are not allowed to consult the modern-day physicians in hospitals or clinics for gynecological issues, for example, childbirth, infertility, etc. Due to a medical complication or an emergency, even if the family relents but the community is adamant about the social norms, then family cannot go against the community's decision and so many women and neonates lose their lives. Similarly, a community may not allow their members to consult a mental health professional as they strongly believe that mental illness is a consequence of religious wrongdoings and God's curse and should only be treated by puja and rituals by the priest. Activity. Observe the socio-cultural context you live in and find out what factors influence the thoughts and behavior of people in such context. For instance, in certain communities, women are not allowed to travel unless there is an emergent reason like medical requirements. Notice such aspects and reflect on the consequences of such socio-cultural practices, values and beliefs on the mental health and well-being of people. Arthur Kleinman, 1988, has illustrated the importance of social and environmental factors in making an assessment through an example. If a man has lost energy because he has contracted malaria, has a poor appetite as a result of anemia, due to a hookworm infestation, has insomnia as a result of chronic diarrhea, and he feels hopeless because of his poverty and powerlessness, does the person have depression? His symptoms meet the criteria for depression, but isn't his distress a result of his health problems and social circumstances and their consequences? Without taking into the context of his problems, we may end up making a wrong diagnosis of depression for this person, which would stall the process of assessment and treatment. A. Family functioning. People's mental health can be affected by their family functioning, which includes the family environment, i.e., organization of the family, family structure, joint, nuclear, family controls, conflicts, and values, communication patterns, the relationship status among the family members, such as are they close/distant to each other, are they so close to each other that they interfere in each other's lives at the cost of privacy, etc. Family functioning can be assessed through unstructured clinical interview by asking some or all family members about their family functioning. It can be more systematically assessed by using observations and standardized tools with a set of questions which can be answered by one or more family members, like the Family Environment Scale, MOOS and MOOS, 1986, Family Adaptability and Cohesion Scales, version 3, Olson et al., 1985. With the help of these assessment techniques, a profile of the family can be prepared which gives a clearer picture of the family environment, its effect on the family members and the areas which require intervention. Ross and Hill, 2004. B. Community. A person's community is also a determinant of his/her mental health. A person with a low socioeconomic status is more likely to suffer from psychological disorders, not only because of his family environment but also because he/she is most likely to live in a poor neighborhood with high rates of crime, substance use like alcohol, marijuana, which exposes him/her to violence where he/she can be the victim as well as the perpetrator. The community can be defined as the place or space in which people spend most of their time. It can be their neighborhood, school, or workplace. Some jobs may be highly demanding and stressful, such as mining, army, police. Most of these jobs may force the family members to live apart, as family stay may not be possible at the place of posting. Absence of a family member, usually a spouse, adversely affects the other spouse, who must take the entire burden of the family. Besides, the work conditions can involve uncertainty and life-threatening situations, being maimed or killed in a blast, battle with enemies. Such work settings may cause burnout in employees. Aziz, 2004, Lindblom et al., 2006. Burnout is not a psychological disorder but a psychological condition that resembles depression. Maslach, 2003. Hence, the clinician must consider the role of community factors while assessing an individual for a psychological disorder. Rosenberg and Koslin, 2011. C. Culture. The importance of cultural influences in the diagnosis of psychological disorders can be understood by the presence of cultural syndromes. That is, not only description of symptoms of various globally prevalent psychological disorders, such as depression, anxiety disorders, depend on the culture of the patient, but there are some psychological disorders which are culture-specific, such as Kayak-Angst, a disorder reported in Eskimos characterized by fear of being lost in the snow-covered dark surroundings with barely any landmarks. Culture of a patient can influence the way the symptoms are reported quantitatively and qualitatively, which affects the assessment and diagnosis of a psychological disorder. For example, while many Americans are less inhibited in sharing their complaints about anxiety or depression, several South Asian people are likely to report somatic symptoms to indicate their anxiety or depression. A study by Taine, Hodds, and Rangel, 2005, reported a study on anorexia nervosa. The researchers found that while white British teenagers reported fear of fatness and preoccupation with their body weight, which are a part of criteria for anorexia nervosa, the non-white, South Asian origin, British teenagers, instead of reporting fear of becoming fat or preoccupation with body weight, reported loss of appetite, not enough criteria to meet the diagnosis of anorexia nervosa. Thus, the likelihood of being diagnosed with anorexia nervosa was decreased for the non-white, South Asian origin, British teenagers, despite presence of significant distress, impairment, and risk of harm. Thus, culture plays an important role in assessment and intervention of psychological disorders. The integration of assessment data. A dynamic formulation is prepared by integrating information obtained from the patient as well as other resources such as caregivers, colleagues, friends, and medical and prison, wherever applicable. This information includes biological, psychological, social, and cultural context of the patient. The dynamic formulation defines the patient's current condition and helps to hypothesize about the factors causing the patient to behave in maladaptive ways. BAPCH et al., 2014. Further, integration of the assessment data into a coherent working model helps in diagnosis, prognosis, understanding the etiology of the disorder, and its treatment plan. A clinician or an interdisciplinary team of professionals, such as psychologist, psychiatrist, neurologist, psychiatric social worker, nurse, physiotherapist, occupational therapists, speech therapists, community psychologists integrate the assessment data into a working model which helps in evaluation of the treatment outcome and in comparing the effectiveness of different therapeutic and preventive approaches. BAPCH et al., 2019. 4.4 Ethical issues in assessment. A clinician or a researcher conducting a clinical assessment has tremendous professional and social responsibility as it has personal as well as social implications. There is a thin line between abnormal and criminal behavior, for example, killing a person and pleading insanity due to hallucinations and delusions in the court of law. Thus, a clinical interpretation may identify a person as a patient or as a criminal. Since a clinical assessment can affect the person and the society, hence, clinicians and researchers should be aware of the sources of bias in the assessment process. According to BAPCH et al., 2019, some of the potential sources of such biases are: 1. Cultural bias of the instrument or the clinician. Due to culturally loaded items, some psychological tests may not be valid to assess a patient from a different culture. Gray-Little, 2009. For example, asking a person from Sri Lanka to name first 4 presidents of USA to measure his /her general awareness is not valid as it is a culture/country specific question. Similarly, if the clinician and the patient are from different socio-cultural backgrounds, the clinician may not be able to assess the patient's behaviors, concerns, and situations objectively. For example, if a clinician is from an individualistic culture and the patient is from a collectivist culture, the clinician will not be able to understand the concerns of the patient regarding leaving a joint family system for career expansion. The clinicians and researchers must ensure that an assessment instrument is culturally fair, like MMPI-2 can be used with people from different cultures. Zapata-Sola et al., 2009. 2. Theoretical orientation of the clinician. Clinicians are trained for specialization in a particular theoretical perspective which influences their perceptions and assumptions about a psychological disorder and its treatment. For example, clinicians trained in different perspectives, such as behaviorism, humanistic psychology, psychoanalysis will assess the same presenting complaint differently. While the behaviorist will view the occurrence of symptoms due to learning, the psychoanalyst will view it as resulting from unconscious desires and motives, whereas a humanist will interpret it in terms of blocked personal growth. Likewise, they will suggest different treatments as per their theoretical perspective. 3. Under-emphasis on the external situation, overemphasis on internal factors such as personality traits as causation of a psychological disorder can lead to inaccurate assessment. So, the clinician may overlook the environmental stressors, which may be the actual cause for the disorder. It not only leads to inaccurate assessment of a patient's problems but may also encourage the clinician to take a different line of treatment. This may maintain or aggravate the problem, as the root cause of the problem, environmental factors, remains unaddressed. For insufficient validation, some psychometric procedures, such as unstructured clinical review, observation, patient self-report and projective techniques have low validity. Therefore, despite being useful, the data collected through such techniques should be cautiously interpreted. 5. Inaccurate data or premature evaluation. Sometimes, data may get contaminated due to uncontrollable extraneous noise, time of the day, unfavorable circumstances of the patient, or internal factors, lack of motivation, dishonest responses by the patient. Further, an individual's data may be interpreted based on group's mean. Additionally, incomplete data may be interpreted. The assessment based on such inaccurate or inadequate data will also be inaccurate and may even cause harm to the patient as it adversely affects the treatment plan. Clinical assessment can be used to the advantage of the person and the society by considering its strengths and weaknesses. 4.5 Let us sum up. In the present unit, you learned about the importance of assessment for psychological disorders. It plays a crucial role in diagnosis of a disorder, and understanding the causes and treatment/intervention of the disorders. The key elements involved in a clinical assessment were explained. Broadly, 3 types of assessment are there, such as biological, psychological, and socio-cultural. Specific techniques under each of these categories were elaborated to provide a comprehensive understanding of the process of clinical assessment of psychopathology. Finally, the ethical issues encountered in clinical assessment were highlighted.